Hi, everybody, and welcome to this edition of Macro Pro and Friends. We're sorry that we started a little late this morning. Unfortunately, we're having some technical difficulties with our guest speaker. We're hoping that she will be able to log back on and make this work. I'm going to go ahead and get started as soon as we're finished with our business, she'll be on. So fingers crossed, keep your fingers crossed for all of us. So hi, Mandy. I am here in the Seattle area, and Mandy, you are in Las Vegas. How are you doing?
Yes, I'm doing great. So I'm here, I'm traveling again. I'm coming live from Las Vegas. Everything seems to be opening up, and I was able to attend a happy hour last night. I'm going to go visit a few clients today. So it's super exciting. It's super exciting for me to go out and see all my people again.
Oh, well, that is fantastic. I'm so looking forward to post-COVID as opposed to, being stuck at home again. So it's lovely that everybody in the industry is starting to get out and about. So what is our topic today, Mandy?
Today, we're going to be talking about brain injuries and brain rehabilitation. We all know the brain is a very complex organ, and it's great to hear on how it can work and how it can change you.
Absolutely. Well, before we get started with that, I'm going to go over a little bit of housekeeping. So the first thing is today's presentation is worth 1 CEU credit. So you must be logged on to the GoToWebinar platform in order to receive your email with your certificate. So make sure you're not just calling in, that you're actually logged on. Secondly, we have handouts for you today, so make sure that you download those so that you can follow along and/or you have them as reference material at the end. If you have any questions for our experts, then you can ask them in the control console question portion, and we will ask them those questions as we go along. So Mandy, can you tell us who our moderators today?
Yes, our moderator, her name is Anne Pereira-Ogan. Anne, can you tell us a little bit about the learning services in partnership with ReMed and how you all work with the workers' comp arena?
Absolutely, and thank you so much. We're very pleased to be presenting to Macro Pro and Friends today. As Mandy told you, I am Anne Pereira-Ogan, and I'm the Director of Marketing and Communications for ReMed in partnership with Learning Services. Let me give you a brief introduction about who we are and what we do. We provide a network of post-acute rehabilitation programs in 10 states across the country. Those include sites in Northern and Southern California, Texas, Utah, Colorado, Louisiana, Georgia, North Carolina, Maryland, Eastern and Western Pennsylvania, and New Jersey. Our post-acute residential programs include active neurorehabilitation, intensive neurobehavioral rehabilitation, and then we have supported living programs, which are community-based, as well as a neurobehavioral supported living program offering. Our non-residential programs include outpatient and community-based programming, and in Texas and California, our home and community programs are active neurorehabilitation programs, which provide intensive skilled rehabilitation in an individual's home and community. The goal of what we do in post-acute treatment following brain injury and other neurologic injuries is to effectively restore maximum function and decrease the likelihood of long-term complications for injured workers and other injured people. We continue to learn that identifying issues and early intervention can greatly increase the possibility for a better outcome. And accessing a post-acute continuum of care at discharge will significantly and positively impact success and reduce complications, including things like poor health, limited function, and low quality of life. Today's session is designed to provide information about brain injury with a focus on increasing insight and awareness, which is a notable barrier to getting the people we treat back on the right track to success. Excuse me. And our ultimate goal, which is your goal as well, is a safe discharge to home, back to work, and back to life. If you have a case, whether it's a new claimant or a claimant needing a change, please connect with us and we can help work with you and provide a brief file review on what might be good next steps to consider, whether it's working with us or another type of provider. So I am delighted to introduce today's speaker, Rene Mills. Rene is a speech and language pathologist, specializing in treatment of acquired brain injury for over 29 years. And currently, Rene is the program director for Remed, or Learning Services in partnership with Remed, for our Colorado and California programs. Her training was completed at Henderson State University and the University of Arkansas for Medical Sciences in Little Rock. She's a certified brain injury specialist trainer for over 10 years. And she's trained healthcare providers in multiple states. Rene is a member of the board of directors of the Brain Injury Alliance of Colorado. She's a member of the North American Brain Injury Society. She is a past volunteer member of the Texas Office of Acquired Brain Injury Supports and Services Subcommittee. She's a member of the American Speech and Language Hearing Association and a member of the ASHA Special Interest Group 2 for Neurogenic Communication Disorders. She was recently honored by the Texas Brain Injury Alliance with an award for professional contribution for dedication in service and advocacy to the brain injury community. I know you're going to enjoy her presentation today. So Rene, I'm going to hand it off to you. Thank you so much. And again, thank you so much for having us today.
Thank you for that introduction, Ann. I just want to confirm that everybody is able to see the screen and the presentation. If you have any trouble, please let me know. So I'd like,
Rene, go ahead.
Okay. I'd like to talk about a topic that is near and dear to my heart, also important for the workman's comp arena. So I want to talk about improving insight and awareness in brain injury, and that is, it's very important, a very important area to work on. Anosognosia, or lack of awareness in brain injury, is the #1 barrier to successful outcomes in rehab. So today our objectives include being able to relate the anatomy and physiology of the prefrontal cortex and frontal lobes to that clinical phenomenon of anosognosia. In other words, where does this arise? Where does this come from in the brain? The objective is to be able to identify Crossan's 3 levels of awareness and insight. And finally, to be able to describe at least 2 effective strategies to improve insight and awareness. Here's a key takeaway point from this presentation. And this is why we do what we do, and this is why what we do is very important to you who have injured workers. There was a study done by Coe in 2012, and it was found that of individuals who were receiving community-based rehab, those individuals whose self-awareness improved by at least 1 level were almost 30 times more likely to be in that outcome group that had successful outcomes, that were able to return home independently to live, return to work as well, return. So you can see that it's critical that we work on improving awareness and insight in brain injury as soon as possible, as soon as the individual is ready, and that we address it throughout the rehab program, because this can result in better outcomes and save money. How many of you have desks that look like this when you walk in on Monday morning? Now, this is an example of poor executive function and insight, because the individual at the desk doesn't know what to start first. He doesn't know what is the most important. And so he's not able to triage, and he's treating every piece of it, and therefore he has this waterfall of paperwork. Not a good feeling. Let's talk briefly about the frontal lobe and prefrontal cortex anatomy. We're not going to dive in too heavily, but I just want to give you a quick overview for the purposes of this presentation. The frontal lobes make up the majority of our brain. We know that they comprise about 20% of the cortex, and the frontal lobes can be thought of as the seat of our executive function, so it's often called the CEO of the brain. Another interesting fact about the frontal lobes, and you can see them highlighted here in the light purple, is that because of the nature of where they're located in the brain and their larger size, they're very likely to be injured in any kind of accident, a rollover, a hit where an individual is in a vehicle and hits a tree. What makes it particularly dangerous is that it sits in the very front brain, right up against the skull, and there are the orbital sockets, there are the sinuses, there are a lot of bony prominences in that area, that essentially function as a cheese grater. They're very sharp, bony prominences, and the brain matter is much like a thick jello jiggler, if you want to think of it that way. And when it scrapes against those bony prominences, it's torn. Blood vessels are torn, axons are torn. So that's the nature and the reason why we tend to see these executive deficits, executive functioning deficits, and poor insight and awareness. So really briefly, what functions does the prefrontal cortex serve? Well, the prefrontal cortex is often thought of as the seat of our personality. It's a regulator for our emotions. It helps us understand our environment and decide how we need to read our environment, how we need to read other individuals, and it modulates our responses we're going to have to those, to the stimuli that's coming in. There are 3 areas of the brain of the prefrontal cortex that are important, and I just want to point these out just for practical purposes. So there's the dorsolateral prefrontal cortex, and that piece, that area really focuses on organizing information that's coming to you. For example, as you're listening to this presentation and you may have no knowledge or very little knowledge of brain injury, you're deciding how to organize this information that's presented against things that you already know. Now, the medial or cingulate prefrontal cortex has to do with motivation and conduct, how we're going to behave, how we're going to be goal-driven. And oftentimes when this area is damaged, we can see individuals have total lack of motivation, not really be pursuing goals to help themselves get better. This can be very problematic during the rehab process. And finally, in the orbital or lower prefrontal cortex, that particular region is involved in our behavioral responses being mediated by emotional components. So in other words, it amplifies or dampens how we're going to respond behaviorally to an event, whether we're going to show irritability, frustration, aggression, or be able to brush it off and continue forward. Now, this next slide really demonstrates in a great deal of complexity how our brain works. I'm kidding. I feel like it was important to inject some humor, but poor Homer Simpson, you can see the majority of his brain is divided into sleeps, donuts, and sweet, sweet beer. Let's talk about some red flags based on damage to those areas we've just reviewed. What are some red flags if you're talking with an injured worker or their family? What would be some flags to you that during a mild or even moderate brain injury that things aren't going wrong? Perhaps they've returned home and left the hospital, and for all practical purposes, they're going to be fine. They just need some time to rest and recover, and maybe a little bit of some red flags that you should be concerned about is tolerance for activity. Perhaps the family member or the injured worker tells you, you know, I don't feel like getting up. I'm tired. I go to Walmart or I go to pick up medications and the noise is too much and it just gives me a headache and I can't handle it. Or I can't go to my kids' class to pick them up. Or I had one injured worker who couldn't go to a football game. They tried right after their accident and they were back home and they had to leave within 5 minutes. Yet another example would be irritability, particularly in the presence of personality that was not highly irritable before. Just a general irritability with talking with other people, with having to process any kind of information. And what may go along with that is a very low noise tolerance. Any kind of loud noises may startle them or make them very irritable. Difficulty reading we see quite often, and that can be for several reasons. One, it can be due to diplopia or double vision that may not have been caught during the hospital stay. It can also be due to true reading comprehension problems that may be separate or independent from ocular motor or visual problems. Some behavioral red flags we may see is that the individual will frequently with others, and more so than they would have premorbidly. They may exhibit a lack of respect for others and treat everybody in a demeaning or condescending way. They may cry more easily, and quite frequently they sleep a lot during the day and require naps to be able to reset their brain. From a memory standpoint, they may miss appointments that you've made for them. or they may frequently lose or misplace things and not know where they are. These are all some red flags you should be paying attention for, looking for when you're interacting with the injured worker or their family. What is anosognosia? That's a fancy term for lack of insight or awareness, and it's not denial. We need to be sure that we're separating that from a psychological phenomenon where someone is actively denying that they have an issue. Anosognosia is the brain not recognizing that it has an issue or that it's having deficits. Clinical phenomenon, but it is separate from denial. Concern is that anosognosia is very frequent in brain injury, and it's as frequent as 97% in individuals who have a traumatic brain injury. So you can see if you have an injured worker who has experienced a traumatic brain injury, you're most likely going to be dealing with someone who has anosognosia or lack of awareness to some level. I'm going to make an effort to show you a video clip, so bear with me for a moment. I want to show you an example of a moderately severe impairment in a moderate injury with moderate anosognosia. So give me just a second here. All right. Oh, it's not going to play. Let me see. There we go. I'm going to pause a minute. I need to give you a bit of background. First of all, this is a female. It's not a male. And she, with her craniotomy scar and her shaved head, she is about 3 months out, 2.5 months out from her injury, and she has left the hospital and she's in a post-acute rehab. She's oriented, so she's no longer in what we call post-traumatic amnesia or PTA. She's emerged from it. However, she's really not aware of why she's here or what she's doing. So I'm going to share this with you now. And she's correct with her time, so I'm going to move on to the middle. She's actually able to relate the time to us, but I want to move on a little more to the center here and resume.
Rene, we can't hear the video, unfortunately. Can you explain what's going on?
Yes, I'm sorry that it's not giving you the audio. Give me just a second and I will play it again. So what I wanted to show to you that this individual who is in our program, who we've given a memory notebook to, believes that we've recruited her to teach and train tennis pros. She's at a school, so she has some level of awareness, but she truly believes that she is with us to play tennis and train folks. And I particularly wanted to highlight the end when she described her abilities. I think that was very insightful. So I may just leave that and I'm going to go back to our presentation. Sorry about that. I wanted to highlight to you what that can look like. The individuals with poor insight oftentimes will sound like they know what they're talking about. They can talk a good game. They can almost convince you that what they're saying is true and accurate and that they're fine and they're going to be fine. However, when you put them to the task of doing something, maybe you're having them perform on a driving simulator and they crash the car 4 out of 5 times on the simulator, yet they say, oh, the problem is with your simulator, it's not set right. There's always a reason for why they're not able to perform what they need to do. And that's why I had this individual, I wanted to highlight her exhibiting that very aspect. We'll move on to the 3 levels of awareness. And if you remember, at the beginning of the presentation, I shared with you that improvement in even 1 level have a significant change in the outcome and a significantly greater chance that a successful outcome will be achieved. Let's talk about 3 levels here. The bottom level, or the entry level, is intellectual and aware. So at this stage, your patient, your injured worker may be aware that something is wrong. So they've done something wrong, but they're not really able to put their is. Okay, maybe they went to pick up the mail and they picked up someone else's mail, or maybe they went and forgot that they picked up the mail already and the box is empty and they're not sure if the mail came or not. They're aware that something has happened, but they just can't solve what it is, and they're not effective in managing the issue. What we like to do is move these individuals into the emergent level of awareness, where the patient can recognize when an impairment's affecting their ability as it's occurring in the moment, right? So perhaps they go to the mailbox and they know that they're supposed to be getting some medications by mail and some communication from their doctor, and they realize it's empty, and then they realize, oh, you know what? I already checked the mailbox and I laid it down in the house. I need to go back in and get that. Of emergent awareness. Okay, that's a good point for them to be at. However, what we do strive in rehab, what we strive to achieve, is that level of anticipatory awareness, where the patient's able to anticipate in advance when an impairment may affect their performance, and they can implement and apply the correct strategy. And I'm going to give you an example that one of my patients did deal with. I had an injured worker who really had issues with low levels of frustration and irritability, and they would lash out and become verbally aggressive, which of course is not going to be acceptable. And a case in point and a trigger was when they went to stores and they had to enter clerks. So an example of during therapy that we talked through, not going to Walmart during the peak hours, going to Walmart early, much later in the evening to get their prescriptions filled, so that they don't have to interact with a bunch of people in line screaming babies and clerks that aren't getting things right. So and so they learn to use those as strategies. I'm going to go when I'm fresher in the morning, I'm not as tired, and I'll go before the rush hits. So those are some that's an example of anticipatory awareness. Do we get everybody to that level? No, but that is what we strive for. Even if we can get them to emergent awareness, quite often we can move through over time and get them to where they're able to have episodes of anticipatory awareness. Okay. There's a fancy word in the rehab world, and it's called metacognition. And that means thinking about thinking. We want to get individuals to the level where they can think about their thinking. And that's a pretty high level goal. But in our mild and moderate traumatic brain injuries, we do want to address this in rehab. And what metacognition consists of is being able to plan ahead, being able to monitor, being able to evaluate situations, knowing what they do know and what they don't know. And while this can sound a little like doublespeak, it's pretty straightforward in how it does help an individual be successful. It's basically working with the injured worker to forecast a situation. If I'm going to pick up my medications, I'm going to therapy, I know I'm going to hurt because I'll have pain with PT. What do I do? These things are what you and I do automatically every day as we adjust our performance according to changing situations, according to changes in moods, fatigue levels. However, individuals with mild and moderate traumatic brain injuries with this, and this is what slows them down and keeps them from being successful. And if you recall in that model of the frontal lobe I showed, a lot of those skill sets in the frontal lobe involve monitoring, evaluating, and planning and critical thinking. What are some strategies we use as therapists? And I won't belabor this too much, but I want to share with you an insight into the therapy world, what we tend to use in our tool belt to help these injured workers. There are a lot of clinical activities that can be helpful, and this is where you have to, when you're working with an injured worker with anosognosia, you may have to pull out several tools in your tool belt because one may work better for an individual than it does for another. I have found one of the biggest successful tools is videotaping someone while they're in, then replay it and let them sit and watch it and narrate it to me. What's going on here? Tell me what you're doing well. Tell me what you're struggling with. Mind while you're trying to do this. This can be a big help because you are not the therapist telling them what they did wrong. You are sitting there allowing them to evaluate themselves. Yet another strategy that is very helpful is role playing with other patients in a group. Person has particular problem, let's say with getting angry quickly or not letting other people talk and not listening to full instructions so that they can successfully complete a job. I'll put them in the role role of being the person who is on the other end of receiving that, and the other person is the brain injured person with the problem, and I let them talk them through that. So role play with peers can be very patients, as well as peer counseling. Oftentimes, I'll bring someone in who has graduated, they've successfully completed their rehab, they're back to work, they're back living independently, they're back driving, and I have them come back and talk to people who are earlier in their rehab stay, and that gives them the opportunity to say, look, you reason, I know you think you're well, I know you think you can go do A, B, and C. I did too, and here's what happened to me. So that peer counseling can be invaluable. Also, when we need objective data to show someone, hey, you're not there, you awareness of your deficits, you're not where you need to be, a cognitive obstacle course can be helpful. We're all aware of those physical obstacle courses, right? There's even one on TV, I think that I forget what it's called, where they have to go through those large circulating structures, and if they are not successful, they fall in the water. Well, a cognitive obstacle course is simply challenging the injured worker in various ways and various activities that they would encounter in everyday life, and having them have it accurately and on time. And I'll share some examples here in a moment with you. Yet another one I would like to mention are rating scales, particularly the competency rating scale, or PCRS. And I'm going to share that with you as you're talking with families or injured workers. It's a tool you could actually use, and it's free. So Prigatano developed, he was a neuropsychologist and developed the PCRS, or Patient Competency Rating Scale. This is what it looks like. It's a form that has roughly 30 to 31 questions on a Likert scale, 5 points from 1, I can't do, to 5, do this with ease. And the first series of questions deal with very visible activities: preparing meals, dressing yourself, washing the dishes. However, and I'm not sure, yeah, I didn't put the second page in, it proceeds on to less obvious, less observable activities to, can I manage my frustrations when I'm talking with someone? Do I find it that I laugh or cry too often and inappropriately in situations? Do I have trouble making friends? So it goes from very visible activities to more activities that are not quite as concrete and are a little bit more behavioral in nature. So the idea is that the injured worker completes this, or the patient, the therapist, and then the family. And then you come together and you put your scores together. You have the injured worker score their own page, and then you compare the scores and talk through those. I just wanted to share that with you because this is something that you can use with your injured workers and families, and I will share at the end where you can get this. It's on the COMBI, or Centers for Outcome Measurement and Brain Injury website, along with a lot of other scoring forms and assessment forms. What would the cognitive obstacle course look like? One of my favorite things is I have them have to pay a telephone bill online. I have them pack a scenario, given a scenario. I have a suitcase full of clothes, cold weather, warm weather. I have a laminated little sheet that says you're going to Michigan, your aunt's funeral, or on the flip side, you're going to Florida for days of a vacation and you have to stop by work to turn in something. So I give two different scenarios and they have to pack accordingly. One of the other gold standards is having them pack a medicine box, pill box, or med minder for a whole week or even 2 weeks. Can they successfully set up and safely set up their medications for a week or 2 week time period without any errors? I have a mailbox sort activity where I took cardboard inserts from like a beverage liquor store where they had wine bottles, and I turned them upside down, and each little segment turned into a mailbox, and I put names there, and they had to take memos and put them in the mailbox and put it in the right slot with the right name on it. I actually had an injured worker who was a postal carrier, and he failed this task, and he proceeded to tell me that he failed this task not because of his fault. It was my fault because I did not set the mailbox up like USPS. I set it up, and that's why he failed. So again, lack of awareness and putting blame on something external for their problem and not accepting their internal problem. You can see what some of the other pieces are. The navigated automated answering service. What better way to see if someone's going to get frustrated or blow up than have them have to go through a phone tree and the menu where they don't get to speak to a real person and they have to carefully listen to all the options and select the right one. I mean, I'm one that's guilty of getting frustrated when I can't speak to a live person after navigating a phone tree. So you can just imagine someone with the brain injury who may have low frustration tolerance and poor awareness. This is going to be a tough one to be able to achieve and to successfully get through. Here's a picture of some of our individuals going through an obstacle course. They're actually going around and having to complete them all, and it is a timed activity. You can see someone setting up their med minder, someone having to organize the clothes to put into the suitcase, and another online trying to pay a bill. So I kind of already gave you this quote about the individual who's the postal carrier. Who blamed me for his issue of not being able to get 100%. He achieved 56% on this mail task, and he was a rural mail carrier. It took us a long time to be able to get him to understand and see his deficits, but we were successful with him finally. I had another individual who said, you know what, Renee, I can go drive right now. I have a valid driver's license in my wallet. No one's taken it away. And even though I have problems with seeing over to the sides, I'm okay to drive. This is my favorite quote. 90% of driving occurs straight in front of you. And I thought, oh my, if he really believes that, I certainly do not want to be on I-20 with him, because that will not be a good situation. So those are some examples of the types of things we hear from injured workers who do have lack of awareness of their deficits. So when you've got someone who's being stubborn, what do you do? What do you do with folks who steadfastly adhere to the idea that they can do this if things are set up right? Well, we need to allow them a planned failure, right? We need to allow them to be able to possibly go home for a little bit, maybe visit the job site. We need to allow them to see that they're not ready. And sometimes this looks like leaving our facility for a few days, having a set period of time to go and try to manage things as they would, and then for us to be there when they get back. And we did that with an individual. He went home for 2 days. He went to try on a pair of shoes, wound up just buying the first pair he found, and he got into a fight with the sales clerk. He tried to call regarding some of his medications and slammed the phone down while his sister was there trying to be supportive. In essence, what he blew up with everything. He tried to drive a truck in their farm, in their fields, and got the truck stuck. So it was an eye-opener for him, and he needed to have that planned failure with the safety net in place. I'm going to pass through this part really quickly. This is more geared towards therapists, but I do talk about the Oreo principle. And when we're working with an injured worker, we need to remember it's the chocolate cookies that are really important when we're dealing with anosognosia, and not so much that creamy filling in the middle. And what that means is our chocolate cookies need to be these two pieces, the before task piece and the after task piece. And even if you're not a therapist, you're an adjuster, an examiner, or a case manager, these are things that should be asked of your injured worker. And these are things that even the families can ask before the task. How difficult is this going to be for me? Will I need to use any strategies? What strategies should I use? Okay, oftentimes injured workers know, hey, I've got a strategy, I probably need to use it, but they don't select the right one for the job. That's why I always talk in terms of a tool belt. They've got to select the right tool for the job. And then finally, before the task is what problems might come up. I call this forecasting, because you're trying to scan ahead and use your executive functioning, use your frontal lobes to anticipate any problems. And then there's the task in the middle. There's the therapy part that happens. But here's the other chocolate cookie, the other piece of the Oreo. After they finish the task, you've got to sit down with them and ask them, or have them ask themselves, how difficult was this for me? I really thought I was going to make 100%, but I actually made 56%. How accurate was I? How much help did I need from somebody else? And here's the money shot. What could I do differently next time? When we're working with lack of awareness, that's the biggest piece. We always want them to get the takeaway of what could I do differently next time. That's how we move folks ahead, and that's how we get better outcomes, is by moving them to that point where they understand, I screwed up, I didn't do as well, here's how I did, but what can I do differently next time? Okay. Some additional things, some additional components of this training that occurs is that we want to set appropriate goals with the client, not for them. If we're going to get their buy-in and they have lack of awareness of their deficits, we have to sit down at the table with them and develop those goals with them. We do want to slowly reduce strategies in our control and our prompts that we give as we notice they're having increased safety and awareness and that they're moving forward in the right direction. We want to remove those as quickly as we can, I would add, because we want to get them to the end point sooner. We don't want to hold on to them any longer than they need, but they do need to go through this process. Also, finally, we want to educate family, friends, and other caregivers so that they can address this with them as well. We want them to help them understand what anosognosia is, how they can prompt them, and how they can avoid getting into those win-lose situations where it becomes argumentative. I'd like to point out, and I think it's important for folks to know, that as we increase awareness and as we're successful on the rehab front, ironically, there can be one negative side effect, and that is we can see an uptick in lower self-esteem and increased incidence of depression for a bit. It doesn't last forever. It's a transitional phase, but it's to be expected that as we kind of burst that bubble that they're fine and we make the inroads that you do have a problem and they understand it and own it and they know they need to work through it, we can see instances of increased depression. So we always have that on our radar, and we know that we need to appropriately involve the counselor, the neuropsychologist, or the psychologist as we see an uptick in that. Some key points that we can take away today for you as you're dealing with your injured worker is that self-awareness deficits affect almost all survivors of brain injury. You know, I think the amount we said at the beginning was 97%. So almost everybody is going to exhibit a self-awareness deficit. Self-awareness, we know, is one of many complex skills of cognition, and it's called metacognition. There are many different strategies to use during rehab, and we've got to select the ones that are going to be most successful for the person we're working with, whether it's a cognitive obstacle course, a patient competency rating scale, videotaping, peer counseling. We just need to select the right tool or combination of tools. Improvements in self-awareness do take time, but they can reduce the length of time that an injured worker is in rehab and can result in better outcomes. So it's incumbent upon us to make sure we address these head on early on and allow for those in our plan so that we will have a successful outcome and can close a case and not have to reopen because we were able to comprehensively address the issues. I'm going to give you some resources here, and I'd like to point out that your second resource, the COMBI website, is listed. If you go to www.tbims.org, which is the COMBI website or Centers for Outcome Measurement in Brain Injury, that will allow you to view and print off for free the patient competency rating scale and quite a few of other scales too. I want to thank you for your time, and my apologies that I couldn't get the rest of the video where it needed to be, but I think we were able to cover the concepts regardless, and I'm open to any questions that you may have now.
We do have a few questions, so let me ask the first one. We have an examiner that says, I have a request for cognitive behavior exam for chronic pain management. What type of session would that be?
So a chronic pain assessment exam. I think the neuropsychologist is going to have to be involved first. A neuropsychologist can tease out things and can also often help with where they are cognitively and assess their sensitivity to somatic issues. And then, of course, a pain specialist needs to be involved. But I would recommend that a neuropsychologist gets involved to assess them as well. I think they can tease out quite a few issues, especially if you're concerned about malingering.
Rene, we have a question. It's asking about a Rancho level that corresponds with or when they should start looking at evaluating for insight and awareness.
Oh, that's a good question. Yes, and we didn't review the Rancho scale here, but for those of you unfamiliar, the Rancho scale is a 1 to 8 scale. It's actually been modified now 1 to 10 that guides treatment based on where an individual is in their recovery process from a brain injury. And I would say that an individual would need to be at a level 7, which is robotic. They go through the motions, but they really only do what they're told, and they're not functioning at an independent level. So I would say for those of you that are familiar with the Rancho level of functioning, it would be a level 7 and above. Any lower, and they're not going to be ready to or able to receive that information you're providing.
All right, so I have another question here, and the question is, can a mild BTI really exhibit impairment in insight and awareness? And what does that look like?
Oh, okay. Yes, I would say yes. A mild TBI certainly can exhibit impaired awareness and insight. And, I would also want to mention that these individuals are the ones that slip through the cracks. These
Yeah.
are the ones who look so good, they fool you. You're ready to close out your case because they're ticking all the boxes until they really get challenged, until they really return to work or they're returning to driving or living home independently. And that's where they fail. They may leave their medications on the counter, and yet when they're telling you, yeah, I took all my medications, and then they have a seizure. Or they're at work, their first few days at work, and the phones are going off. A lot of people are asking them for things, and they're trying to go back full time instead of a slow ramp up because they can do it all and they're ready, and they fail. They have a meltdown. I've seen it. I've seen it time and time again. So it's important that when we see these mild traumatic brain injuries, we're really assessing their level of insight and awareness, because those are the ones you're going to close the case on and you think you're fine and it's a success, and then it blows up. So that's a very good question.
We have
Other
another
questions?
Yeah, there's one more. It says, how can you tell the difference between a minor injury and one that may be caused by narcotics and alcoholism? The writing is small, so I hope I got that correct.
Okay, so I'm going to interpret that to mean, how can you tell the difference between a very minor brain injury, maybe a concussive injury, versus one that was caused by alcohol or narcotics? In the ER, Sometimes it's hard to tease those out. You start off with the toxicology screen. The individual may appear impaired because they're under the influence. As they're released from ER and they go back home because it is mild, I think there are some differences when there's alcohol or narcotics involved. They're going to clear. They may have the withdrawals, but with a mild traumatic brain injury, you're going to see complaints that are a bit less, well, I don't want to say a bit less somatic, but I want to say that there's going to be a cognitive and memory piece that may not be present with the alcohol and narcotics. And if you feel that you're not comfortable determining between the two, a neuropsychological screen, if you don't want to do a full battery, just a screen could be helpful to tease that out.
Well, here's a very interesting question that would apply to everybody, not necessarily somebody who had some type of work comp injury. It says, is heart rate an indication of a TBI?
That's an interesting question. No, it's not. We do know that with TBI, we can see excessively increased heart rates, and there are some cardiac problems like POTS syndrome. I've had a few individuals who have a TBI and develop POTS, which is an irregularity in their heart rate, and it shoots up suddenly and they sweat. That's associated with some brain injuries, but I can't say that a heart rate is an indicator of brain injury.
Well, thank you so much, Rene, for coming and speaking to us today and working through the difficulties of technology. You know, technology is so wonderful until it's not. And we appreciate your professionalism and your can-do attitude. We really appreciate that. So just a reminder to everybody, you will be receiving your certificate today, probably within the next hour. It'll come from GoToWebinar. If you need a copy of today's handouts because you were unable to download them, please feel free to email me at Diann, D-I-A-N-N, @macropro.com. We can assist you with all of your records needs. So if you need to get records for your litigated or claims files, MacroPro is here for you. All right, until the next time, thank you all, and we'll see you at the next MacroPro and Friends webinar.